Thank you so much. And again, thanks to the We Care organizing team for this very kind invitation. Just want to, little trivia. I gave the same talk 25 years ago in Lucknow when Dr. Mittal organized the SCCon there. And I mean, a lot of things have changed, but many things actually have not changed. So my talk is early postmenopausal osteoporosis. So the operative word to keep in mind is early. Okay. So the one thing I want to start with by saying is, while longevity has increased dramatically in the last 25 years, I'll reference 25 years, 50 years, whatever, the age at menopause has remained exactly the same, around 50 for globally, and maybe Indian women somewhere around 47, 48. So the age at menopause has remained the same, but women are living well into their 80s and 90s. So you can see that there is a big chunk of our life we are spending in the postmenopausal years. And as you can see from this very frequently shown cartoon, that at the menopause there is a dramatic drop in bone mass, and also that kind of goes on for about 5 to 10 years. And if we had a question, which time of the menopause, the perimenopause and late perimenopause, when do we lose a lot of bone? You can see both in the lumbar spine and total hip, even in the late perimenopause and the immediate postmenopausal years, we lose a lot of the bone. And that's something to keep in mind. And just to pay homage to Fuller Albright, who was the first person to actually think that estrogen could be responsible for osteoporosis. He just observed that many of his postmenopausal women were having fractures, and he thought, postulated that postmenopausal osteoporosis is possibly from estrogen deficiency, but subsequently tremendous work has happened in this space. But just want to show you what estrogen can do to the osteocytes. It decreases apoptosis, and then other mechanisms, changes activation of bone remodeling. At the osteoblast level, decreases apoptosis, decreases oxidative stress, decreases NF-kappa B activity, and then other mechanisms, again contributing to maintenance of bone formation. And then when you come to osteoclast, increases the apoptosis and rank ligand-induced differentiation, therefore decreasing bone resorption. So just flip the script and think of what would happen if there was estrogen deficiency. The opposite of all this would happen, and therefore net-net, people will have more of bone loss and less of bone formation, and therefore there's no surprise why all this is happening. And this cartoon I put up just to show that it's not such a simple thing of just working on osteoblasts and osteoclasts, but it's at other levels. And if you drill down, the mechanisms are at the Wnt signaling pathway, at sclerostin level, and at the rank ligand level. At every level you can see when the presence of estrogen, what it can do, and estrogen deficiency, how it can lead to bone loss. So if you if you are faced with a woman in her early postmenopausal years or in the perimenopausal years, let's just say 50 to 60 or something like that, and you're faced with this question of osteoporosis, what do? Do a good history and physical, which is very important for everything. And is there any laboratory evaluation we need to do? And then what kind of imaging needs to be done? And of course the role of FRAX, which is like a poor man or poor woman's tool for evaluating osteoporosis. Quickly in history and physical, we definitely want to take history, menopausal history, because towards the end I want to talk about hormone therapy. So one group, that is the women who have premature menopause or early menopause, this doesn't come into that discussion of, are we going to give them hormone therapy? We definitely want to take them up to natural age for menopause if there are no contraindications. I think that's settled and there's no question about that. But it's for people who have gone through the menopause already. afterwards should we be giving hormone therapy. So you definitely want to get the history of things like menopausal history and breast cancer and their vitamin D status, and definitely medical history for secondary causes. Manoj just talked about glucocorticoids, so taking history of medications. And when you're talking about a physical exam, we all know that osteoporosis just presents with a fracture, but you want to look at the BMI and if there is any kyphosis and again, signs of secondary causes. When it comes to laboratory testing and imaging and things like that, really very minimal workup in terms of getting a CBC, and I would definitely look at a calcium and albumin as a surrogate. We don't need to really look at even vitamin D till you have established the osteoporosis. Then I do want to know their vitamin D status, because nearly 50% of people have an osteomalacic component to their osteoporosis. Bilizicane has shown that very nicely. And at what age group should you start screening women for osteoporosis? Definitely not in 30s, 40s, and as part of some master health checkup and things like that, but really for women. In our women, 5 years after menopause or 55, whichever comes first. Or if, obviously if you have broken a bone and you have other serious risk factors, you could consider them at a younger age. But otherwise, not the NOF guidelines of 65 and 70, but move them all up 10 years, so 55 and 60 for our population. So one thing that I really want to stress here is that we should be looking at the spine, because incident vertebral fractures are things that we do not know, and patients usually do not come to us that they've broken their back. They may have some vague, non-specific back pain. Unless we do this in some form, a VFA or an X-ray, we are really not going to be knowing what is going on with their spine, and that's very, very important. And that will also completely change risk stratification. When it comes to management, the calcium and vitamin D and the importance of weight-bearing exercises, and now sleep is added to that, and good nutrition, and no-nos being alcohol and smoking and excessive caffeine. All of these things we have to have major discussions with with women in their perimenopausal, and what not to go to, especially in terms of things like phytoestrogens and other things that are especially sold over the internet. When it comes to pharmacotherapy, while we have this big laundry list of medications available, actually we only have about 3 now, which are the bisphosphonates, oral or IV, and we have denosumab, and we have the anabolic agent teriparatide. The others, abaloparatide and romosozumab, we don't have them yet, so we only need to talk about these 3. And oral bisphosphonates are something that in India, we're not big fans of because of lots of instructions that patients have to have, compliance and adherence to therapy. All these have been issues. So IV bisphosphonates, denosumab, and the anabolic agent teriparatide really are what we are going with. The IV bisphosphonates are powerful, effective, except for a flu-like acute phase reaction that some patients may have, usually well tolerated. So that seems to be our first go-to choice. If they have, of course, CKD or other issues, denosumab is always an alternative, knowing that we cannot, we have to continue the treatment in effect probably, always, or we need to go to another agent if we are thinking of stopping denosumab. And and as far as anabolic agents, that we have teriparatide, and would choose it for women who have very severe osteoporosis, who have fractured on a bisphosphonate, or continue to lose bone on a bisphosphonate. This would be the choice of patients for an anabolic agent. And as you can see, all of these are very, very effective, but we really don't go with agents like ibandronate or aloxifene because they have not shown hip fracture efficacy. In the last 6 minutes, I want to address the elephant in the room, which is hormone therapy for women with osteoporosis. So since I showed you that estrogen is what is really needed, keeps the bone healthy in women and in men, and estrogen deficiency is what causes postmenopausal osteoporosis, it just seems like a no-brainer thing that you give estrogen and everything is going to be fine, right? And that's really what we thought for the longest time. But we also know that hormone therapy has gone through this. It's the fountain of youth, it's a poison. Again, good medicine, bad medicine, poison. And finally, after the WHI, I think all the nails have been set in the coffin, and it's been like bad medicine. So hormone therapy had fallen out of favor in a very, very big way. It is kind of having a little bit of a rebirth because of a phenomenon that I'm going to explain to you. Even in the Women's Health Initiative, which is the one that came out and actually did a randomized controlled trial of women, with a uterus, without a uterus, estrogen plus progesterone, estrogen alone, and looked at multiple, metrics and variables, and finally told us that it is not safe for many reasons, and I'll show you. But one thing it did show was it definitely decreased the risk of fractures. So we do know that. And when you use estrogen, you can see, especially with current users, continued users and current late users, it definitely increases bone density, no question about that. But what happened with the WHI was, while it showed a decrease in hip fractures, but it also showed an increase in risk of breast cancer and stroke and pulmonary embolism and coronary artery disease, and also a decrease in colorectal fracture. But if you just look at this slide, in the younger people, those risks seem to be less. In the younger people, overall those risks are less also. But as people get older, obviously the risks are more. And the other thing that is particularly not in the favor of estrogen is once you stop the estrogen, the bone loss continues and you kind of go back to where you started. So it's not, you have to continue it indefinitely. And when you continue it indefinitely, then you start running into those risks of complications I just mentioned. So this is a summary of the risks and benefit of the menopausal hormone therapy from the WHI, and you can see whether it's coronary artery disease or PE or thromboembolic disorders or stroke and things like that. There was definitely an increased risk. Diabetes came down, fractures came down, colorectal cancers came down, and if you take out the younger women, overall mortality was less. And what about the dosage? The higher the dosage of estrogen, obviously the better the bone density was. But one important thing that has come up, and since it's supposed to be newer perspectives, is that this whole timing hypothesis. So if you take younger women and give it to them right after they undergo menopause, are things any different? So in the timing hypothesis, you can see if they're under 60 years old and 10 years since the menopause started, they seem to have even less of the other complications that we are talked about in older women. And again, this is a summary of all risks and benefits of hormone therapy, and you can see while those benefits I've mentioned are there, the risks are particularly high, especially if you continue it for more than 5 years. What do the professional societies say? Obviously, it can't be a one person's view. So whether it is the US Preventive Task Forces, and they obviously have given a D, which is not a distinction, but a bad score for hormone therapy. So they say combined estrogen progesterone for primary prevention of any chronic complications with an intact uterus has no net benefit. And the same thing they've said for people without a uterus also. And what about ACE 2020 postmenopausal osteoporosis treatment? Again, no role for hormone therapy. What does Dr. Canis say? And so he segments them into low risk and high risk and very, very high risk. And only in the low risk, he talks about consider menopausal hormone therapy and SERMs, and again, depending upon the individual that you're treating. And then finally, the North American Menopause Society position statement also does not recommend hormone therapy for prevention of chronic diseases. But what I would draw your attention to is this very recent editorial by Deborah Grady, who we all know is a very big researcher, and Alison Wong, who talk about menopausal hormone therapy for prevention of chronic conditions. When is enough enough? They're not talking about when is enough as in dosage, but when this chatter about hormone therapy, when is it going to be enough? So their conclusion is the time has come for us to put this whole hormone therapy for chronic conditions to bed. Use it for women who are symptomatic with hot flushes or other serious vasomotor symptoms for shorter duration, lower dosage, and better formulations, not the ones that were used in the WHI, like conjugated equine estrogen or even medroxyprogesterone acetate. Use more natural estrogens and more natural progesterone for a shorter period of time, but always keep in focus that if you use it for a longer period of time, you have to increase the surveillance considerably. And the surveillance of the patients, mammography or looking at their potential risk for other cancers and all of those things, and vascular complications will have to go up and will have to be intense. So this is their conclusion. But my thing is our core purpose of all this treatment is actually prevention of fractures and good quality of life. So talking to them about all those things I mentioned, calcium, vitamin D, good exercise, good sleep, good nutrition, fall prevention, and avoiding alcohol and smoking and caffeine. And for those individuals who need pharmacologic therapy, choosing the appropriate one and screening them using the current recommendations. And fall prevention advice, because if you don't fall, you usually don't fracture. So the fall prevention advice is very, very important. Thank you so much.